Good afternoon, everyone, and welcome to Grand Rounds. My name's Tom Fowden, and I'm the chair and organizer of Grand Rounds. It's 2026. We're now into our sixth year of doing it remotely like this on Zoom, not Teams, as some people seem to think, on Zoom, and streamed and also put onto YouTube. It's actually our 11th year of doing Grand Rounds in the manner we've been doing it, and it's the 13th year that I've been chair of the Grand Round program. So we've been here a while, and that perhaps just shows how old I am. Another thing that shows how old I am is that one of today's speakers I first met when she was a medical student. And now is a consultant pediatrician here back in Tayside. And what a delight it is for me to introduce her today to give a talk at Grand Rounds. Perhaps we would never thought we would have been in this situation when we first met in 2000 and oatcake, huh? So, as I said in my email splurb, we have two back-to-back talks from the pediatric department, and both talking about nutrition. But our first talk is from Lorna McKerracher and Marianne White, who are going to speak about, as you see on screen, supporting, protecting, and sustaining breastfeeding in conflict zones, with particular reference to the conflict in Gaza. Next week will be a more general talk, and we're live in person in the Wolfson Lecture Theatre, streamed across on Zoom. If you want to join us in person, you can do that. So I think Lorna's kicking off, and then Marianne's going to be chipping in and out. They're going to talk about their work with the GINA, Gaza Infant Nutrition Alliance, over the last couple of years, including how it was set up and what work they've done. If you have any questions, please do put them in the chat, or you can wait until the end, put your hand up and ask it in real life. Feel free to leave your camera on if you wish, but please do mute during the presentation and then unmute if you have a question at the end. So, Lorna, thanks very much for coming along. Marianne's also, and looking forward to your talk.
Thank you very much, Tom. So it's lovely to be here today. I'm one of the neonatal consultants here in Tayside, and Marianne White, my colleague, is one of the infant feeding team members. And we have been volunteering with GINA, as Tom said, since 2024. Over the course of the talk this afternoon, we'll be just trying to outline the key challenges with regards breastfeeding in the context of emergencies and conflicts, which is maybe not something that you've previously thought about before, but we'll be introducing, I suppose, some of the ways in which breastfeeding and infant feeding in general can be really, really challenging in these settings. We'll be looking at how we can explore practical strategies to maximise breastfeeding, but also reduce the risks of formula feeding in those particular contexts. And then thinking about the Gaza Infant Nutrition Alliance, specifically thinking about the lessons and challenges that we've encountered, lessons we've learned, challenges we've encountered, and how we've had to kind of flex and think outside the box a little bit, using our previous experience in our own contexts here in Scotland, but to apply them in a culturally appropriate and trauma-sensitive way. And we'll be introducing a case that kind of reflects that need to adapt. And then just to finish, thinking about how we can apply the strategies discussed in our own context. And I suppose that's, for many of you, might not seem like a very obvious link, but I suppose we all encounter breastfeeding or infant feeding challenges directly or indirectly, depending on the patient groups that we encounter, and how can we help foster a really supportive environment. And then at the end, a wee plug for medics and medical students on the call as well, who might be interested in breastfeeding medicine. So just as a reminder, for everybody, what the global strategy for infant and young child feeding is. So UNICEF and the World Health Organization both recommend that breastfeeding should be started as early as possible, within the first hour or so of birth. It should be exclusive for the first 6 months of life, and continued in addition to complementary solid feeding for at least 23, 24 months and beyond. And that is acknowledging that formula feeding may, for whatever reason, have to be a part of that process, but that is the ideal for babies as the physiological norm. But in resource poor contexts, the importance of breastfeeding is very much increased, and certainly non-breastfed infants under 6 months in resource poor contexts are 8.3 times more likely to die than breastfed infants. And those children aged 6 to 24 months who are not breastfed have double risk of mortality compared to breastfed infants. And the cost in terms of increased morbidity across the world for children who don't breastfeed is huge, and it's estimated that over 800,000 children die each year because they weren't breastfed. And these figures were very much put to the fore in the Lancet breastfeeding series in 2016, just highlighting again just how breastfeeding is a hugely important public health measure, and particularly so in resource poor contexts. So why do we want to protect breastfeeding in an emergency? So during emergencies, feeding infants and young children, as described before, becomes even more difficult, but even more important, arguably. And there are some very practical challenges for families. So their ability to cook safely and cleanly, maternal health is impacted, and there's real disruption of the social support that goes around raising children and babies. There are huge difficulties with displacement, constant evacuations and relocations, overcrowding, no privacy. Breast milk substitute donations and distributions might be well-meaning, but these are not associated with consistent and reliable supply chains, and they can quickly become part of a black market of formula, which means that families have to pay huge amounts of money for single tins of formula. And some of the families that we've been engaging with in GINA have had to pay up to $50, $60 for a tin of formula at times. Myths and misconceptions about breast milk and the value of breast milk compared to formula seem to be much more prevalent in the context of emergencies, particularly when charities may be donating formula. And really understandably, with the ongoing stress and trauma, the lack of a safe place to live, that's really hard for families to remain confident in their infant feeding choices. And even if they did feel that they wanted to breastfeed, that they may feel that the need for adequate nutrition in the form of a tangible product might be preferable. And all these things contribute to increased malnutrition, and ultimately morbidity and mortality increases as well. So why is formula feeding so dangerous in emergency settings? And really, I think, particularly where we are lucky to live in a resource-rich setting where we don't really think about formula being potentially dangerous, it's important to remember that infant formula powder is never sterile, and it's a product that can be contaminated, and particularly when there are inadequate ways of sterilising water, sterilising equipment. Access to clean water is almost impossible. It's really difficult to ensure that pathogens won't enter the formula and become harmful for the baby. Bottles and teats in particular are an extra source of infection, just because with all the nooks and crannies within them, bacteria can be harboured. And of course, you need fuel to be able to heat fires, to sterilise water, to heat water adequately, and that comes with a cost. In that way as well, it's also important to just consider that infant formula is potentially an adequate source of nutrition, but it doesn't offer any of the active immune protection that breast milk can offer as well. And we've talked a bit about the challenges in resource poorer settings, but in high resource settings also, it's not that we are immune to the potential risks associated with formula feeding, and we know that there's increased risk of hospitalisation for babies who have less exposure to breast milk, and we know that this is a dose dependent thing. And just even in the last week or so, we have been involved in trying to ensure that all our neonatal families are aware that there has been a recent recall of batches of infant formula due to the possible presence of cerulide toxin, and 37 countries across the world have been affected by this potential contamination. So it really is a real issue. And equally, although we might not think about it, the UK also is potentially vulnerable to emergencies. We're living in uncertain times at the moment, but equally from an environmental perspective, there are challenges that sometimes make it really difficult to protect infant feeding. Power cuts related to snowstorms might make it impossible for a family to safely prepare formula. And the UK woefully scored a score of 0 out of 10 on emergency infant feeding preparedness in the 2024 World Breastfeeding Trends Initiative review. All countries should have an infant and young child feeding and emergency policy or crisis response plan with adequate training, and sadly that doesn't yet exist in the UK as a whole. And Marianne is part of a working group in Scotland looking at this very issue. So Marianne, I'll hand over to you.
Thanks, Lorna. So I was just going to tell you what our strategy was in Gaza when we were faced with trying to support breastfeeding within this current emergency. Next slide, please. So as Lorna was saying, there's a lot of risks about accepting infant formula in emergency. The Gaza Infant Nutrition Alliance was set up because there was calls for fundraising requests to buy formula so we could send it to Gaza, and we got in touch and kind of said, this isn't really a great idea. Infant formula isn't the best in emergency situations. We really need to be supporting breastfeeding. And Reem, who's this amazing emergency doctor in Lothian, was like, okay, how do we do it? And we were like, oh, well, we obviously can't do that. But what we did was just start. And I think that's really important with any situation you come up. Just begin and see what you can do. And 2 years on, through a lot of PDSA cycles, we've kind of got a system that's working, and it's really culturally appropriate. And the most important thing, I think, is that it's with the staff that we're working with in Gaza. So the formula issue is that women who are living in emergency situations like this, there's a lot of myths, and part of our work was to debunk these myths. So feeling that stress and trauma and upset really affects their milk quality and their milk supply. There isn't the support they usually have. A lot of them, their mothers and their sisters have been killed, so they don't have that support around them. They're displaced not only once, but a lot of the families we look after have been displaced 8 to 10 times, so they don't have that community support around them. There's a lot of marketing around formula. There's even in the news, you can see that women who are malnourished can't breastfeed, and it's about debunking those myths and working with the population we serve within Gaza. Next slide, please. So like Lorna was saying, there isn't the privacy for women to feed their babies. If they're in hospital, they're often very overcrowded. There's a lot of family pressure. The infant feeding culture within Gaza is very similar to Scotland, and there's a lot of formula use before we were in there as well. And then the cultural beliefs, again, just that the fear and stress would dry up their milk. There's a lot of women that are worried that they might be killed, and so they want their baby to get used to bottle feeding just in case, and they don't want to be reliant on breastfeeding. So it's about supporting the families through all these kind of really difficult situations that we've been trying to do. Next slide, please. You probably know from the news, or maybe not, because it's not often in our news, sadly, but there's a huge amount of displaced people in Gaza. The hospitals are damaged. Also, our medics, nursing and midwifery staff are targeted. We've got to be really careful about the information we have, the information we share, and making sure we keep them as safe as possible. There isn't food security. The borders are still shut, and there's no access to clean water. They also think, and perhaps happens, that the water is contaminated, the water stopped, and so breastfeeding is the best thing for these tiny babies. So what we did was, there was a small team of us that started in the beginning. Reem and Yafa got in touch with local teams. It was just one neonatal unit, and this has slowly spread to over 4 hospitals now across Gaza, with more coming on board. We've trained local health workers, and we also now pay them 3 days a week to be part of our GINA team, which has been really instrumental. We also have been asked by UNICEF, MSF to train their teams, which has been really good just to keep that consistent message. And then Reem's also worked with the Ministry of Health into kind of banning formula milk, because it's such an unreliable source, and the different kinds of tins that come in are not always appropriate for those babies. So they can only really get formula from pharmacies, and that's with a thorough kind of breastfeeding assessment beforehand. We also established a remote service model, and that's where I'm involved heavily, where we have gathered a team of lactation professionals and Arabic translators, and we work together to provide infant feeding support. This is integrated with mental health support, because all the women we support do have trauma, living in these conditions and trying to bring up a young family within really unstable housing. We do a lot of work within the neonatal units, promoting early colostrum, skin to skin, and making sure milk expression is happening within the first 24, 48 hours. Yafa, who's one of our training leads, has developed amazing Arabic resources. We've got that for the mothers. We've also got that from the staff. We did it on YouTube and Zoom and Google Meet, but often the internet is not working in Gaza, and so we also managed to record our training sessions and get them into Gaza on little memory sticks, and the staff could watch it there in their own time. Another really supportive thing is that we've got virtual peer support groups, and we know with infant feeding that mother-to-mother support is really valuable. So we've got, within WhatsApp, you can get 1,000 people in a group, and now we've got 3,000 mothers in these groups. So as you can imagine, the questions that come from these groups is quite a lot, and so we're trying to work to make sure this doesn't overwhelm our team. The mothers support each other, and we've also got one of the WhatsApp groups is a cook it scheme where they know what the food available in Gaza is, and for making complementary foods for their children, they share recipes and then they win a prize at the end of the month of the sharing. And it just helps people share recipes, share ideas, and it also helps that support for the mothers. We collaborate with NGOs and Ministry of Health around Gaza and trying to prioritise breastfeeding and reduce the introduction of formula. We've managed to get a few breast pumps into Gaza, but it's really hard to get even a breast pump into Gaza, and MSF workers take these pumps with them in their bags. We managed to provide pumps for mothers where they're particularly malnourished, or if their baby's got cleft lip and palate, or if the baby's in the neonatal unit and too little to feed, we try to be able to provide them with breast pumps there. Because the mothers are always on the move, we do a lot of work with carrying babies, and we've done fundraisers for slings and supporting that. It's good for skin to skin, but it's also good when mothers are displaced. The families in Gaza often have larger families, and so it's been really helpful to have this wearing the babies and safe wearing of babies there. We started up a remote service to do supporting women as they move around, because the hospital staff are overwhelmed, and we thought this would be something we could take on to support. The first mother that I supported was 2 years ago. She had a baby who was discharged in the neonatal unit at 32 weeks, and the baby had a 30% weight loss. This wasn't something that an infant feeding advisor here would support. So working together with Lorna and Reem, we managed to support her to cup feed her baby, and the little one is now just over 2, and the mother still sends us pictures, which is really nice. So the babies are referred to us from the teams in Gaza, and now we only accept the higher risk babies. So these are babies under 2.5 kilograms. They've maybe got a genetic condition or something like cleft lip and palate. There may be preterm, or they might be a twin or a triplet. We had 2 sets of triplets in November. I then triage them to decide who can support them and to try and get them support quickly within 24 hours referral, and then we triage them according to this list. Once we've triaged them, we were working within one team, but now we have over 60 volunteers. So we've got lactation consultants and Arabic translators from around the world. Next slide, please, Lorna. And we receive the referral, we put them into a bubble, we call it, which is a WhatsApp group with the lactation consultant, Arabic translator, and we give them support until they're happy on their feeding journey. If the mother doesn't have WhatsApp, we often find a family member. So last week I was translating and working through a grandfather who was supporting his granddaughter whose baby was in the neonatal unit. And this again just builds up that family support that's really important with infant feeding. And it brings the message into the community about the importance of breastfeeding and breast milk. If nobody has WhatsApp, we can phone them and work through a 3-way call to support their infant feeding journey. Sometimes if there's different things going on, we can bring in Lorna or Monica, a medical doctor from Portugal or other places around the world to support that specific case. And it really gives the women an understanding that we care for her, we're seeing her, and we're supporting her on her infant feeding journey. If things are difficult and we want them to have face-to-face support, we get in touch with our Gaza teams within the different areas of Gaza, and they see them there. They get back to us and we understand how the feeding's going. Part of my work recently has been to update our spreadsheet and to collect more data, just so we can get funding from different places, and also so we can work with UNICEF in kind of meeting the targets they're expecting and getting funding to do this further and for people to be paid for the work they're doing, especially in Gaza. So our team has now grown. We were quite stuck in a bubble where we were just firefighting and supporting on our own, and we've reached out and now managed to get over 60 volunteers. It's a little bit different because people speak different languages, they're from different time zones, they've got different practices, but we're starting up a CPD and a reflective practice session. I've just finished the Scottish Quality Improvement and Safety Fellowship, and through that I met clinical psychologists, and I've been in touch with them and kind of recruited them into this, and they're now working on a model to support our volunteers, because there's a lot of vicarious trauma and kind of burnout within our team because of what we're seeing and what we're doing. And so we've kind of identified that, and hopefully we can move forward to support our team so we can support more mothers. On to you, Lorna.
So I'll just briefly talk about one of the aspects of Gina's work that I was involved in probably initially about 18 months ago, relating to the neonatal unit. So I think it's fair to say, as Marianne said, that the culture within Gaza pre-2023 was not necessarily breastfeeding as the default. And specifically in relation to colostrum, one of the myths that we discovered was the sense that that first colostrum that is produced wasn't very good quality. I think the kind of thick stickiness of it, the belief was that it was that it wasn't good, wasn't safe to give baby, and almost to wait until that first bit of milk had passed before the better quality milk came. When we reviewed the current feeding guidelines with the neonatal teams in Gaza, we realised that, as was the case here in Scotland and elsewhere in Europe, maybe 10, 15 years ago, where there was a real fear about necrotizing enterocolitis in extreme preterm babies, and a worry that feeding babies early put them at increased risk of this. The Gaza guidelines very much focused on babies being completely nil by mouth for the first few days. So that, along with the fact that the colostrum wasn't being expressed and wasn't being given to babies, meant that the potential for mums to build up a milk supply was vastly decreased because they didn't have that early stimulation of the breast. And equally, we now know that babies who are not fed early on are at increased risk of GI tract atrophy, and there's far more understanding that buccal colostrum is a very specific oral immune therapy. It's got very, very good absorption in the buccal mucosa, and that way the baby, without having to take big volumes of milk, can still get the benefits of secretory IgA and the lactoferrin that helps prevent the proliferation of pathogens in the gut, to provide that very localized protection. So we felt it was really important both to get those early benefits for our babies of the buccal colostrum, but also as a way to help promote and support and stimulate milk supply early on. Really important to introduce this idea of buccal colostrum from as soon as possible after birth. And that's something that we've been working on in our neonatal unit as well. So in June 2024, I think this is when it first started, we linked in with the neonatal units at Nasser, Al-Aqsa and Al-Hulu hospitals. And I had adapted with colleagues in the west of Scotland, the West of Scotland neonatal enteral feeding guidance, which had just been updated at the tail end of 2024-25 and adapted it for the Gazan context with the team in Gaza. The team in Gaza then did a whole series of education sessions with staff within the neonatal unit to try and debunk all those myths that we've discussed and really emphasise the importance of breast milk and colostrum and giving it buccally. Skin-to-skin practices were, again, not universally practiced previously, and part of the practical reason for that was that there was limited privacy within the neonatal unit. Here in Tayside, we're very lucky. We've got very lovely pull-out screens that go around the cot side, and that enables mums to feel safe and supported to be able to have skin-to-skin and breastfeed with dignity and in privacy. In the neonatal units in Gaza, we had to kind of think outside the box and create screens with whatever we could. So staff used sheets or sheets of MDF, and those were used to really change the culture around skin to skin. Supporting mother's nutrition was something that we felt was really important to do. As Marianne mentioned, there is a lot of mistruth about the fact that mums who are malnourished can't breastfeed their babies. They absolutely can. There is definitely a physiological and biochemical toll on mums when they do that, but the picture of this colostrum here shown is from the neonatal unit in Nasser Hospital in August of 2025, which was really at the height of the aid blockade and prior to the ceasefire. And as you can see, there's very much still the ability for mums who were had high rates of malnutrition to be able to express and provide colostrum and breast milk for their babies. We also focus within GENO on providing financial support for families to be able to obtain transport to get to the neonatal unit. What little transport is available is very expensive, and it's far harder to be able to express milk if you're not close to your baby. We also had to kind of think slightly outside the box, because recognising that mums weren't necessarily able to come to the neonatal unit often, they wouldn't be able to refrigerate milk in their living circumstances, living in tents. So there was no way really of storing the milk that was expressed safely, much less being able to give it to a vulnerable preterm baby. But yet it was still important for her to express, because it's that continued stimulation and expression that enables a full milk supply to be developed. So our advice to mums was simply then to use the milk for other children in their family, or to mix the milk that they expressed with oats and grains to make porridge, so that it wouldn't be wasted. And similarly, at the times when they might be given free formula or donations from well-meaning charities, for the mothers to drink the formula to get the nutrition for that, and to concentrate on breastfeeding their babies. And as Marianne said, all throughout this, the remote service WhatsApp group enabled mums who were expressing for their babies in the neonatal unit to have that individualised support based on their own medical conditions, their own challenges with breast and nipple anatomy, potentially with regards expressing and eventually transitioning to direct breastfeeding. I think it's fair to say that this project in relation to not just a kind of quality improvement approach, but introducing aspects of family integrated care, which is very familiar to us in neonatology. All of these things have been very well received amongst staff and families. This is for the neonatal colleagues on the call. This is the enteral feeding guidance that was adapted. You probably recognise it from the West of Scotland document. And crucially, just along the right-hand side there, just ensuring that as soon as possible, all mothers are receiving expressing and lactation support from the GINA team, which is something that we also try very much to provide here in Scotland. And this is a quote from Hadil, who's a primary school teacher, and her son Malek was born at 34 weeks in Nasser Hospital. And she said expressing milk was difficult and it took a long time, but the feeling is indescribable when you give it to the nurse to give to your son. And certainly I think, again, for the neonatology clinicians on the call will very much be familiar with that sense of pride that the mothers have when they walk into the unit with even just a tiny syringe of a few drops of colostrum, knowing that they've achieved that. So Marianne's just going to talk about a case that she was involved in.
Just thought we'd give you some context to the type of cases that we get, and this is one of what we get within the remote service most weeks. Within the remote service, we support between 90 and 180 mothers a month. So this is new mothers, and sometimes we get referrals that need particular support, and so we use the expertise within our team who can do it, who's got the right qualifications and experience to support. So our director got in touch with me saying this mum really needs support and it needs to be done every day, and we need to make sure we can do it. So this mum was a nurse in one of the hospitals in Gaza, an anaesthetic technician, and she had a baby. She already has a little one who was 10 months old, and then she had a little baby born at 30 weeks that was 1.4 kilograms. The baby was discharged at 21 days, so just over 33 weeks, which we wouldn't do here, but because of the safety in Gaza and the importance to get out of the hospital, babies are discharged really early, and it's really important we can give continued support to keep on the right track. So this little one was then readmitted back to Al-Aqsa Hospital with malnutrition and sepsis. They had antibiotics, and then they were home. So it was really important that this tiny baby who'd already suffered from malnutrition at such an early age was given the support they needed. I messaged the mum. I worked with an amazing translator called Rula, who's a Syrian refugee who's training to be a GP back in Manchester and who's one of the loveliest people. And so together we've called the mum and spoke to her about her situation and what we could do to support her. She said, I don't have a tent. I don't have a safe place for my family to live. I really need a tent. I've got a little one who's 10 months old and I need support to buy a tent. The baby was being breastfed 4 times a day and was given around 250 mils of formula. We messaged every day. We try not to, as an infant feeding charity, get involved in aid because we don't want to have people that we give aid to and others we don't, but it is often the situation is so dire that we do try and reach out to other organisations. And for this mum, we managed to buy a tent from a different organisation and the family set it up within 2 days, which was really good. We messaged her every day. She was managing to have time to hand express. There was no breast pumps available, which is often the case. So she was living in a tent and feeding her baby, and then after feeds, managing to hand express so she could give this really valuable express breast milk instead of relying on formula and unsafe water. The baby's weight increased. We send resources such as this. We've got lots of resources, some of which are translated from our NHS Scotland resources into Arabic. Others we've made ourselves. We've got videos, and there's also the global media that also has lots of really good videos, but it's just if the mum has data to download it. So she managed to increase the baby's weight from 500 grams, which was amazing. And we continued to support her to reduce formula and increase breastfeeds. And the baby was now only receiving 2 formula feeds. These are just some of the resources we managed to send over on WhatsApp. We measure how babies are doing in this country and in Gaza by their weight, but often that can't be taken, and so nappies is really important. But in Gaza, they also can't get nappies, so that was another thing we had to change. And we usually say 6 wet nappies and 2 full dirty nappies, but if you can't afford nappies, the nappies stay on for longer. We've got videos about how to make nappies out of bits of plastic, about old surgical gowns and material, and these are just some of the things we do to support the women within our care. She was increasing breastfeeding frequency, she was feeling it was more comfortable, and she was being able to feed her baby as she wanted to. Sadly, when we called her on the 22nd, she said the family's tent has been shot at. Her little one, who was 10 months old, had been killed. She'd been injured in the back, and her husband had been injured on his leg. It's really hard to know what to say. After that, she was reaching out to us again for support, and Rula and I would call her and message her. We provided support for the whole family and also tried to help her find a different position to be able to feed her baby with injuries to her back in a tent where she didn't have a mattress, no pillows, just some blankets. We also managed to get in touch with an orthopedic surgeon who we shared the husband's x-rays with and tried to get her support from there, just showing to her that we can see her and we're providing her support and we do still care about her. Her milk supply decreased after this. We suggested lots of skin to skin to try and help her feel safe and cared for and loved, and we continued to provide reassurance and support. The beginning of July, the family's tent was fired on again, and the mother sustained quite severe chest injuries. She was moved to a hospital, and the baby was taken with the granny and the dad, and they were around 40 kilometres away. She had really severe wounds, and she didn't have much pain relief. She would message us and video us pictures, and it's really difficult. And we tried to get in touch with staff at the American hospital and our MSF colleagues just to try to visit her and give us the support she needs. But obviously this is the situation for most people in hospitals in Gaza, and so it was really difficult for her. We managed to be in touch with the grandmother about formula feeding and safe bottle feeding, and when the mum was back out of hospital, we resumed contact and we found her again, and we started support to help her with relactation. Sadly, this is the case for many of the women we support. They really are amazing women and being able to feed their babies in these situations. And to be able to support infant feeding in emergencies, we really need to support early breastfeeding, the early establishment of milk, increase the mother's confidence, and she can do this. You have enough milk, and your milk is the best thing for your baby. And really reducing within the teams, within Gaza, the media, and within our country, how unsafe it is for formula feeding in such situations, and that isn't a safe alternative. And the best thing we can do is to support expressing breast milk, cup feeding before bottle feeding. Making that emotional connection with mothers is really important, and then building that support with mothers around them in the communities they have is also really important. And our approach has been to work with the staff. We haven't gone in saying, here's our guidelines, this is really what you need to do, this is a great QI project. The staff have come to us asking for support in what they want to do, and I think that's been a real key to success. The staff are amazing, and despite living in such terrible displaced situations themselves, often without enough food and water, they still continue to come up with ideas of presentations, QI projects, things we could do better, things they need, things they can do to support us within our remote service. And so in like a PDSA type fashion, our charity has kind of evolved, and hopefully we continue to do that, to provide this really low cost, high impact intervention to support mothers to feed their babies. These are just some of the quotes from the mothers to our team about the support they have been given from the circle of love that is within GINA and to them. So we'll just give you a minute to read them, and I'll hand over to Lorna.
Okay, so I suppose key takeaways for today, just really emphasising that there's no way that this can be done by one person. It's very much a team approach, and breastfeeding as a team approach anyway in optimal circumstances, but very much in the context of emergencies or conflicts. I think the key thing about the Gaza conflict is that it's so ongoing. It's not time limited as many emergency situations might be, and access to relief from some of these circumstances has been very, very challenging. But we've seen within the GINA team the amazing power of mothers supporting mothers, and the fact that we have 3,000 mothers on a peer-to-peer support group is really quite inspiring. We really need to remember that there are so many different factors that impact breastfeeding, and so the emotional and physical support that goes alongside giving really individualised care is so key. And I suppose that's where, in my role as a kind of neonatal clinical advisor, I've also really, I'm very grateful to various colleagues in other specialties, in dermatology, infectious diseases, microbiology, who have helped provide contextual advice for some of the mothers, their babies, the siblings, and that's really helped to give that that sense of support at a really stressful time, and protect breastfeeding overall. And really just the fact that lactation issues in this population who are high risk requires specialised support, really. I think it's fair to say that it's the norm now that babies in Gaza are low birth weights, that they are all slightly preterm, and there is an increased rate of congenital abnormalities. So having that specialised lactation support, infant feeding advisors, and breastfeeding support workers giving advice through the remote support team and through the Gaza team on the ground is absolutely crucial. These are not normal breastfeeding circumstances. But cultural context is absolutely everything, and there's a whole lot more we could talk about the cultural sensitivities with regarding wet nursing or donor milk, but the important thing is to be in constant communication with the teams on the grounds, and as Marianne said, not imposing anything on them, but really being available when help is asked for. So there's lots of different ways that you can connect with GINA if you're interested in finding out more, via email. We have a website, Facebook page and Instagram, and some QR codes to go with that as well. And then just finally, as a wee cheeky plug, I would just like to highlight the existence of the European Association of Breastfeeding Medicine, and I recently joined the board of directors for this group, and all the doctors who volunteer within GINA within Europe are members of the EABM. It is a relatively new organisation which has been set up to try and promote and protect and support breastfeeding, but acknowledging the unique role that medics have in advocating for breastfeeding. We as doctors, whether we realise or not, have a lot of power when it comes to infant feeding choices by the things that we say or sometimes don't say. It's really helpful to be able to have an organisation that allows that improvement of education, both at undergraduate and postgraduate level, to create guidelines, but then also to influence policy as well. Anyone of any specialty can join, and in a whole range of specialty, not just in paediatrics and obstetrics and so on. There'll be mothers of childbearing age who may be breastfeeding, who may have medications that may or may not be compatible, and it's useful to be able to have that source of support and a point of contact. It's only €30 for doctors to become a member, and €10 a year for students, so well worth it. And then more locally, if you're a student in Dundee, please think about joining the Breastfeeding Medicine Society if you're interested. This was set up by two now fourth-year medical students who did an SSE with us in the neonatal unit and undertook some QI work related to early expressing. There's an exciting programme of educational events, journal clubs, and communication skills practice and OSCE training that the team are putting together. So thank you very much. I'd be delighted to take any questions if you have them.
Yeah, fantastic stuff, both of you, on so many levels. I said in my preamble email, there are currently, I think, 53, 54 states currently in a state of war in the world across 35 different countries, and we see it remotely, don't we? We watch the news, we see social media. And it really hits hard. The photos you showed and the comments from the woman out there saying what she wants most in the world is a tent. I think it's what a really powerful message. It's really very sobering when we go on social media here and whinge that our internet speed is a little bit slow, and can somebody come and salt our path? So I think the work you're doing is amazing stuff. I know Reem well from work I've done with her. It doesn't surprise me at all what she's done to set this up. But then it doesn't surprise me that you've done this either, Lorna, and along with Marianne. So what amazing stuff. So there are some questions in the chat, but there's a hand up. So if David has put his hand up, he gets to go first.
Hi.
Hi, David.
Hello, how are you?
I'm good. It's that David. Hello.
It's this David. Thank you very much. That was such an impressive piece of work that you're doing. So for somebody, I've been to Palestine. I have lots of friends there, and being Arabs, they would not be happy if I didn't pass on the thanks from all the Palestinians for what you're doing. You may not know, you may know we do a lot of work supporting medical education in Palestine, including we bring students over because they really don't have resources. And actually, they're being forced into actually delivering healthcare because there really is not a lot of resources. And actually, when you were talking, I was speaking to one of my colleagues who's in Jenin in the West Bank. So people, it hasn't really been publicised, so they have flattened the refugee camp in Jenin, and there's now 25,000 people that are living in the hills. And actually, they're starting to see exactly what you've been talking about. And this is a plea, and I can follow it up, so I'm not asking you to commit yourself into anything and doing great work. But I wondered if you would be willing to host an online talk with people in the West Bank to raise awareness of this, because it's a big problem that they're starting to see now. The infant mortality rate is starting to rise significantly. And I think, even something to raise awareness amongst them, that they can start to think about what they can do. I'm not asking you to do what you've delivered in Gaza. I know how busy you are and the amount of work these things take, but I think it would be very beneficial to them. And I asked them if it would be something they would be interested in, and they were like, definitely.
So our work's been recognised by MSF and UNICEF, and they want us to continue our work in Gaza and move to the West Bank. They also talk to us about Ethiopia and Sudan, but we do this all in our own time, so we kind of have to ensure what we're doing in Gaza is done well, but we do want to support. So we are in the process of working with the UN to gain funds so we can stretch our work into, and with the West Bank would be first, but we would be more than happy to talk to them and raise awareness about what they can do, and maybe with support with medical education, we could help their staff there do the very beginnings of this kind of work.
The person that we do most work with, they have a large charity that supports a lot of projects in Gaza around mental health, childhood trauma, all of these things. So there may be some good link there. But if even an hour presentation to them would be fantastic. It would be greatly appreciated by them.
I think it's fair to say that although, as you can tell, a lot of this was started outside of Gaza, we obviously needed an in, and we haven't mentioned, but one of the key catalysts for this work going forward is a resident doctor called Amira, who has since been evacuated to Ireland, and she's now doing a master's in public health just in the last 5-6 months or so. But it was her speaking to Reem and really understanding the importance of this issue to then emphasize that to her colleagues, and then the kind of ripple effect happened after that. So I think there's definitely potential for that same kind of model happening within the West Bank, and and there's definitely a recognition amongst the NGOs, Save the Children, WHO, that education is the key to this, and just you don't know what you don't know, and particularly when priorities and conflicts may be related to trauma and resources go in that direction, infant feeding is kind of seen as a lesser issue. But I think we can absolutely help to support, and it feels like there's so much that could be done, but having a key contact in the West Bank would be great.
I'll drop you an email.
Perfect.
Thank you.
I don't tend to copy paste in the comments so I'll read them out so that they get on the YouTube channels in no particular order and not saying who they are. But fantastic talk, humbling, inspiring in equal measures, incredible work, really interesting, important work. Thank you. Thanks, Lorna and Marianne. Incredible work, truly impactful. The stories are harrowing. Amazing work. Thank you for presenting. Fascinating talk. Thank you. Really interesting, moving and powerful. Thank you, Lorna and Marianne. Such a powerful, impactful presentation. So that's the sentiment that's coming through from the audience, and I'm sure that's shared across the whole of the audience today. So thank you very much for volunteering to give the talk in the first place. I mean, thank you really for volunteering to do all the work you've done. just saying you were to do a grand round is such a fraction of all the things that you've done, and I'm sorry for missing your email way back in November, but we get there in the end, eh? Thank you to the audience for being here and listening. This will get edited and go up onto YouTube in due course. Next week, we have another talk from Paediatric Nutrition, and but I think it's a general talk about nutrition in infants and children in general, rather than specifically in war-torn areas. But it will just be as interesting. It will be in the Wilson Lecture Theatre, so I'll send out an email early on next week to let you know what to do, where to go. But live in the Wilson Lecture Theatre next week, simultaneously live streamed across Zoom. And on that note, thanks again for the talk. Have a good afternoon, everyone. Have a good weekend, and we'll see you all next week. Take care. Cheers.
Thanks, Tom.